my own case, I just had the full yearly workup with my doctor, and usually he does test homocysteine. For some reason, this year didn't. Checked my B12, checked my folate, homocysteine is not on the Quest work. I'm like, what happened? I think I put 6 to 8 as an optimal range.
Yeah, 6 to 8 is a perfect optimal range. And actually, lower than 6 is not great. So people who sometimes come in with 4 or 5, sometimes it's a problem. Sash, it's a little too complicated. I don't think we need to go into it. But basically, if you have a CBS mutation, there's a shortcut that happens. So people drop into they bypassing glutathione and they overproduce sulfates, and that's rapidly degrades homocysteine. But it's not rare. I see this once every couple of months. Yeah, so, it's not all that unusual. It's rare in the settings of seeing patients in the standard of care or things like cardiac disease, Alzheimer's. Usually, even if someone in the younger life had such a low homocysteine, later in life it starts going up because eventually, CBS mutation becomes more and more silent. There's some data on it. But anyway, I don't want to bog you guys down with this. It's irrelevant for today's conversation. I'm just explaining that you're absolutely right about 6 to 8. So it's not like 0 to 8. That's the point here. But even things like 9, like if somebody starts from 20, and believe it or not, occasionally I see homocysteine of 20 or even more, like 30. It's very, very unlikely they're going to go from 20 to 7. Like I can count on my fingers the situations like this. Usually they'll go from 20 to 10. And I actually going to say that's fine. Like I'm going to say this is probably as good as it's going to get with someone like that.
Yeah.
So this also need to take that into account. So the percent improvement is sometimes just as important as the absolute number.
Do people with really high homocysteines have side effects immediately, or is that something that just increases your risk of all these problems later down the road?
Correct. They're not gonna come in and say, I have high homocysteine, it's causing such and such. You're never gonna do that. It's a side issue. So it's a marker for future complications.
Well, it also depends how it plays into your brain chemistry, I would say. It's quite possible that you might have like more ADHD symptoms, maybe stronger PMS or something, just because your methylation cycle is not running properly, and maybe you're short on semis. But yeah, it's not like high homocysteine is directly doing something. Now the question is, if you improve somebody methylation, are you going to see his mental status improve?
Yeah, I don't know. I don't really see that. Like, I don't think I've ever seen that. Like, I've never seen a patient. See, I guess it's really hard to assess. That's the problem. Because usually when people come in, we would work on multitudes of different angles at the same time. Certain metabolic parameters improve, and then the patient feels better. Are they feeling better because there's a homocysteine or is there something else? I don't think there's an easy way of saying. And I don't actually think that homocysteine as a measure causes specific symptoms per se. It's simply when the certain symptoms occur, like depression, for example, you could expect to see homocysteine being somewhat abnormal. There's one big exception, and that's a B12 deficiency. So when somebody is really B12 deficient, they're going to have both MMA, methylmalonic acid, and homocysteine high.
So this actually also begs the question, what is normal B12? Right.
Right. There is no such. Unfortunately, that question is impossible to answer because there is no norm. The serum levels are useless, pretty much.
Yeah, it's not what's in the tissue.
It's a completely useless test. So homocysteine is much better test because it's a functional test in essence. B12 in the serum, no one knows what it represents. It's just the level. I mean, you could have level of over 1,000 and have deficiency.